And yeah, and without further ado, we'll just hand things over to Dr. Bailey so that she can go ahead and get started on this very important topic.
Hey, hello everyone. Thanks for bearing with us today. And I will share my screen if I can. Sarah, can you let me?
Yes, I think you should be able to now.
Okay, great. Great, so today we're talking about treating complex trauma and understanding it in children and adolescents. So basically what we're going to do is understand what complex trauma is in children and adolescents and really how it impacts and how you can recognize it in each developmental stage going into young adulthood, and some of the effects within adulthood, and then some evidence-based treatments. And we'll apply it to a brief case presentation. Okay, so understanding trauma. Nearly half of children from birth to age 17 have experienced some type of trauma, not necessarily complex trauma, but some type of trauma. So it's not as rare as we think. If we're thinking about those ACEs, those adverse childhood experiences, nearly half of children, nearly half of us in this room have experienced at least one type of trauma, whether that would be child abuse or neglect, to a natural disaster, to one of those adverse childhood experiences like having a parent with substance abuse or mental illness in the home, or a divorce, or separation. So adversity can be all these things. They're not necessarily things that leave a bruise, and they have a negative long-term effect on children and adolescents. So many of these stressors, especially when they're chronic and pervasive, have these long-term effects. So sometimes we think when there's one big traumatic event, that is what it causes PTSD, post-traumatic stress disorder. And we think of, okay, a child was in this traumatic war zone or was raped. And we think of that as, okay, that kid had trauma. But the kid who is in this chronic environment of feeling unsafe day after day, and these chronic, but it's not that big event, that can often have just as much, if not more, of a lasting effect on their life. So, complex trauma. The majority of children who have trauma histories have had multiple traumatic experiences like we've been talking about. And complex trauma really disrupts secure attachment. And that's really what we're going to be talking about. The main problem that leads to all these adverse outcomes is complex trauma disrupts secure attachment with a healthy adult and the primary caregiver and that early brain development. So it results in this pervasive emotional, behavioral, and somatic, so physical and cognitive dysregulation. So your whole body, mind is dysregulated. So when I work with highly suicidal individuals in dialectical behavior therapy, both adolescents and adults, and dialectical behavior therapy is most commonly used for borderline personality disorder. And I often tell people I don't like that name. And I say that borderline personality disorder is really just complex trauma all grown up. It's your way of surviving when you're young and dealing with a dangerous world, and now it's wreaking havoc on your life and it's just not working anymore. So let's find a way to live your life in a way that works for you to live your best life. And borderline personality disorder is chronic emotional dysregulation. And we're seeing here that complex trauma is just, it's chronic and pervasive emotional, behavioral, somatic, cognitive dysregulation. So it kind of like that's that connection. So these kids, when not treated, when we don't intervene, become those adults. Especially when they don't have a healthy, secure attachment with a caregiver or a healthy adult. So that's when it results in that physical and mental problems reaching into adulthood. And it's not just mental health, it's physical health, it's cardiovascular problems, it's, it leads to other things like diabetes, high blood pressure. So how can trauma affect the brain? These are the main places that trauma affects the brain. The prefrontal cortex, amygdala, and hippocampus. I am a social worker. I'm not a neuroscientist, but this is just a basic overview of how it affects the brain. And what it really does is it shows it puts kids on the express road. So it affects these parts of the brain that help us process, that help us go from problem solving to processing something that just happened and thinking about it and evaluating some options and making a decision. And evaluating whether something is dangerous or not dangerous, to those kids that just go from 0 to 100 and react and go from this is dangerous in a second. We often think like, oh, how do you go from 0 to 100? How do you just react? Like there is time in between. And that's because kids who have been in chronic unsafe situations, their brain develops this express road where they no longer have that pathway of processing. So chronic trauma just shapes every aspect of a kid's life and really profoundly affects their sense of self and identity, or really disrupts their idea of even having a sense of identity. And even if they have no memory of what happened, we often think like, oh, that kid's never going to remember that, so they're going to be okay. And that can sometimes be the most profound effect because it's disrupting that secure attachment, which is like the #1 indicator of that kid having complex trauma and long-lasting effects into adulthood. So what about early infancy and childhood? Like this quote that says, it is the ultimate irony that the time when the human is most vulnerable to the effects of trauma, which is infancy and early adulthood, we often presume that those kids are going to be resilient. It's the kid that is, in the other room in the crib while a lot of domestic violence and things are going on. Like that kid's not going to remember that. It's the kid that witnesses things before those memories form. It's the kid whose, parent like was not with their parent for the first year of their life, who was because their parent was in jail or in treatment or in different things. Like that can often be the most profound effects. So what are signs of complex trauma in infancy and early childhood? It's that hyperarousal. It's that quick reactivity, trouble sleeping, not it's harder to calm and soothe that child, that irritability, some delays, especially in sensory and motor skills, digestive issues, and dissociation. And I won't read through all of these effects, but effects of trauma in the development of infancy and early childhood is really that they misinterpret. They're just starting to, and this lasts, into adulthood. They misinterpret first their caregivers' actions as dangerous. Sometimes their caregivers' actions may be dangerous, but then they're misinterpreting these cues as their caregivers' actions as dangerous, even when they're not. So then that actually makes the attachment even worse. So if the caregiver's actions sometimes are dangerous, or someone else's actions are dangerous, and then they react to the caregiver when it's a healthy interaction as dangerous, then that further makes that attachment more insecure and more detached, which makes them even more at risk. It makes them less independent because they're clingy and needy, which also makes them have worse relationship with adults. They also, aren't able to self-soothe, and they have this learned helplessness. We know when people have agency, then they're more resilient. So this learned helplessness makes them less resilient over time. And they learn that their emotions are frightening and dangerous. They know that they learn that their emotions and their body sensations are frightening, and that's dangerous. And then their behavioral problems then often they start to get labeled as lying, manipulating. And then they internalize that I'm the bad kid. So complex trauma and the caregiving relationship, we've already touched on some of this. There's that insecure attachment with caregivers, and often the caregiver has complex trauma themselves. It's that multi-generational pattern of grandma had complex trauma, leading to mom had complex trauma, and now kid. It's just that multi-generational pattern. And so this leads to, we can't treat complex trauma in kids and adolescents without addressing the effect on the child caregiver dyad. And even when the biological parent is not there, we still need to address complex trauma with the child and the kinship caregiver, or the foster parent, or the adoptive parent, because we need to form secure, healthy attachments. So I wanted to show you this diagram. It's really showing this like bidirectional relationship. It's this kid with complex trauma who develops behavioral problems, and the behavioral problems cause parenting stress and negative parenting. The parenting stress and negative parenting also cause the behavioral problems, with which feed into the complex trauma. And then you also looked at the parenting stress and the negative parenting strategies lead to insecure attachment. So they all are bidirectional. They're all feeding into each other. It's not just the kid has behavioral problems, which lead to negative stress and parenting problems. It's also that the parenting problems and negative parenting strategies lead to behavioral problems, So it's going around in a circle. It's all messed up. So kind of intervening at any place is important, and getting it from multiple angles. That's why getting the caregiver involved is really important. And that insecure attachment, even when the original biological parent isn't there, to have that caregiver involved. Now, the effects on trauma in middle childhood, in middle childhood, we're starting to venture out and have those relationships with teachers, with coaches, with peers. And that child with complex trauma is not capable of making those healthy relationships. They socially withdraw. They don't have those social skills. They have reduced social achievement. They are, I think the statistic is twice as likely to have an IEP, and they have that negative self-concept and that hopelessness, helplessness, self-blame. They internalize it. Kids want to believe in their parents. So kids internalize that I'm bad because they want to believe that the world and their parents are safe and good. So they start to internalize that they're bad at this age, which they lose their self-identity, or they have a negative self-image, and they mistrust themselves before they even mistrust the world. And then they start to have these behavioral problems and internalizing disorders like depression and anxiety. Going on to trauma on adolescence, that's where, adolescence is where we form our self-identity. And adolescents with complex trauma have this very disconnected sense of self. If we think about adults with borderline personality disorder, one of the symptoms is this lack of self-identity or self-worth. And so this in adolescence, kids with complex trauma adolescents, they have this negative self-identity, or they're very disconnected from their self-identity. They often have re-victimization. So, they're misperceiving danger cues and social relationships. So if they were victimized, sexually abused in the home, they may misperceive attention from a relationship from an adult or a peer, and then have further physical, sexual, verbal abuse patterns into adolescence and adulthood. They seek out those risky sexual behaviors because perhaps they feel that that's the way that they have self-worth or are loved. Effects on young adulthood. This is when people start to become severely functionally impaired, may not be able to work, function in higher education, develop mature and healthy relationships, difficulty with that pervasive emotional dysregulation and executive functioning and memory, and like dissociation and personality disorders may start to develop. So how do we help these kids be resilient? It is helping them to feel safe. And the thing is, when I work, when I was working, when my primary appointment was over in behavioral medicine and psychiatry, I ran a psychoeducation / support group for non-traditional caregivers of kids with complex trauma. And what was confusing to them is the kids are safe now. Why are they still having all these problems? And it's because the kid doesn't realize they're safe yet. Their brain's not registering that they're safe. The kid doesn't, even though they're in this safe home with loving caregivers who want to support them, they've been unsafe for so long they don't trust it. Their brain's not registering yet. So helping them to realize they're safe, being consistent and patient, having a supportive, long-lasting, healthy relationship with a caring adult. I always tell my students that can't be you. I think when I was young too, I was just, maybe in the back of my head, I was just like, oh, they don't have anybody, but we can't be that person because we come and go. There's high attrition. We don't know where our career is going to go. Finding them that person who may or may not be the adult in their home, but a coach, a neighbor, an aunt, an uncle, a grandparent, someone who is a supportive, long-lasting, healthy relationship. When I work with my adults and I am looking at who is who has these trauma histories and who actually has a borderline personality disorder, and who doesn't. There was one time where people sent two young adults to me for differential diagnosis. They were like, does this person have bipolar 2 disorder or borderline personality disorder, or both? And I actually had two people sent to me at the same time. They had a very similar history of pervasive emotional dysregulation and a sexual abuse history in the home. But the one had this grandma who was always their safe person and was still their safe person. And that person didn't have borderline personality disorder. That person was just as dysregulated. And they had bipolar 2 disorder, but they had a sense of self. And they had this resilience. And they had this supportive network and they didn't have this hopelessness and loss of identity. So they didn't have both disorders. So this lasting and supportive relationship is the number one factor that helps build resilience in these youth. So our case example is meet Olivia. She's a 5-year-old of mixed ethnicity. Her parents used substances, primarily heroin, alcohol, and marijuana. And there was frequent violence in their relationship. The family moved 4 times during her first 2 years and was homeless once. Her mother would leave her with friends or other relatives for brief periods. Olivia and her mother moved into a shelter when she was 3. But her mother returned to her father after 6 months. 2 months later, Dad was incarcerated because of domestic violence and multiple intent to distribute charges, and he was arrested in front of Olivia. Olivia was removed from her mom's custody 3 months later after alleged allegations of neglect and physical abuse. And in the past year, she's lived in 3 different foster homes and was just placed in her current foster home. Olivia's mother has been unable to comply with service plans requiring treatment of her diagnosed bipolar disorder and substance abuse. So, what in Olivia's experience would you consider traumatic? You can call out or put it in the chat. What would you consider traumatic and why? Domestic violence, drug abuse, neglect, being removed, moving, witnessing domestic violence and drug abuse and arrest. So witnessing the different foster homes at 3 in a year, now a fourth, being removed, bounced around. Exactly. There's so many things in her young, like the insecure attachment to her mother now. Exactly. Her mother's untreated mental illness and substance use. Yes, so many things. So what do you think she's learned about relationships, and how do you think she might react to people? So there's no safe object consistency. Exactly. People are terrifying. There's no connection, no trust, fear of abandonment. Love equals pain. So I can't love people or I'm going to be in pain. Need to be distant. Exactly. So even when people try to reach out those healthy relationships, she may push them away. So those poor self-regulation skills, she might not be able to self-soothe. Oh. So working with kids with complex trauma, she might not trust that her basic needs are going to be met. So a lot of times I see people saying they're stealing. I'm like, what are they stealing? Often they're stealing food. Why do we think they're stealing food? Because they didn't have food. So in the middle of the night, they're like hoarding food in their room. So what's helpful? We get them a snack bin. So they always have access to food. They don't have to go grab food and sneak it. They always have this basket where they can get food. So they have that food security. Or I had a foster mother, or actually adoptive mother at that point, I think, who the kid had Christmas decorations in their room. And huge behavioral episode, like breaking, throwing things when they tried to take the Christmas decorations down. And mom was like, what's going on? This was just huge reaction. Like we need to punish her. Like what is going on? She'd been in 13 homes in her life. She was never somewhere long enough that the Christmas decorations were gonna come back next year. So she didn't trust that they'd put them up again because she didn't think she was gonna be there again. So how do you think this has influenced Olivia? What do you think she's learned about herself in the past 5 years? You can keep putting it in the chat. Insecure, unsure of herself, and afraid. She's not worthy. I'm worthless. She's not a priority. Difficulty learning or being accepted. I'm not enough. I'm unlovable. No one wants me. Exactly. And how do you think she got through this? What survival skills do you think she's learned? Not to trust. Yeah, maybe some self-injury and distance. Don't get attached. I can only rely on myself. Don't expect anything from anyone. And she might be really parentified. She's 5, but she might be doing a lot herself. She might like cook. Like, so a lot of times these caregivers will be like, the child wants to cook and they're really young and, you know, they're not allowed by the stove. And it's just like, well, you know, in their home, if they didn't cook, they didn't get fed. So now it's like kind of almost like a power struggle. Like the kids are really confused why they're not allowed to use the stove if they cooked all their meals before. Isolate. Exactly. Asking for help is challenging. You know, accepting help is challenging. Ah. So now let's go into some different treatment models. And then while we're going through these treatment models, think, what might you refer or use with Olivia? And there's not necessarily a right answer because we know that the number one thing that creates outcomes is the therapeutic relationship and those non-specific factors. So I think 40% of outcomes is the therapeutic relationship. And I forget, like, I think like 30 is also those non-specific factors like empathy and positive, unconditional positive regard and all of those things. But it is also really important, at least 15% of outcomes are when you have a specific evidence-based treatment that matches the problem, you know, and the focus and the individual needs of the client. So some evidence-based treatment for complex trauma recommended by the Children's Traumatic Stress Network are the attachment self-regulation and competency framework. So what I like about this intervention is it's flexible. It can be used with children and adolescents 3 through 17 who have experienced complex trauma. It was designed for complex trauma, not a single traumatic event. A lot of these interventions were designed for more like PTSD, a single traumatic event, and then were expanded for complex trauma. This one is unique that it was designed for complex trauma and always involves the caregiving system. It's designed to support the youth and caregiver to engage with the world and empower in future-oriented ways. A lot of these kids aren't future-oriented. I remember asking a 12-year-old, and this is in my 20s when I first started working with youth with complex trauma, like where he thought he was going to be when he was 25, and he just told me he thought he was going to be dead. And I remember like being so surprised, but they have no future orientation. Like they don't believe that they're going to be alive at that point, because that just makes sense given what they've seen from the world so far. So empowering in this future orientation rather than being focused on day-to-day, moment-to-moment survival. What's also cool about the attachment self-regulation and competency framework is it can be done in individual sessions and then individual with the child, individual sessions with the parent, co-sessions with the parent and child. It can be done in home, in an office-based setting. It can be done in schools. It can be a trauma-informed approach for like an agency. It's very flexible. It has these different components of attachment, regulation, and competency, all working towards trauma experience integration. So first, you really work with the caregiver at the bottom of the pyramid, the bottom of the house of the ARC framework. And it used to be a pyramid actually, but they made it a house because they're really stressing that secure attachment within the caregiving relationship within the home. And the attachment, they're really working on engagement in the caregiving relationship, psychoeducation about trauma, about how parenting a kid with complex trauma is different than parenting a kid without complex trauma. When I work in that in that parenting group, it's just normalizing, like, you're not parenting wrong, it's just different parenting a kid with complex trauma. They respond different to rules and limits and discipline. You know, we got to rethink things. Their brain is just wired differently. The importance of routines and rhythms, and how to have that attunement and that management of your own affect and effective response, and then really working with the kid on their own emotional regulation and their identifying of their own emotions and body sensations, and then working with them on their own identity and helping them with their functioning at home, in school, socially, to then work towards integrating that trauma, rewriting that story. And there's also trauma-focused CBT, which is what many people are familiar with. Originally designed for children who experience sexual abuse, very effective. It has been expanded for complex trauma, for youth with all developmental levels and across cultures. It can be structured in short term, in between 8 and 25 sessions, really individualized to the child adolescent. I can include a caregiver. And it has these different components. Again, that it can have psychoeducation, it can cue kids about safety, and also teach kids relaxation, so that, and emotion, again, emotion identification and emotion regulation, and understanding thoughts and feelings and behaviors. So then when you go to do a trauma narrative, really understanding the trauma that happened and rewriting that narrative and doing it, and then processing that narrative with the parent, that the child has these coping strategies, the relaxation, the emotional regulation, to be able to use when processing that trauma narrative. There's parent-child psychotherapy, which is a model for younger kids, 0 to 6, who have had at least one traumatic event. It's based in attachment theory, so really targets that insecure attachment, but also some other theories. And it always includes the child and caregiver. And it aims really to support and strengthen the relationship, and then also the child's functioning behaviorally, cognitively, socially. So working at that pervasive dysregulation at all those levels. And there's also structured psychotherapy for adolescents responding to chronic stress. This is more for adolescents, 12 to 21, who have experienced chronic interpersonal trauma or separate traumatic events. And it's in a group, which can be really effective for adolescents. That group, it's normalizing that other people are going through this. Often adolescents really respond well to feedback from their peers, and like what their peers say can be more powerful than what the therapist says. The goals are really raising awareness and coping effectively, that connection with other people, which we talked about. Really, they have the dissociation and social isolation in adolescence, which can really lead to those adverse outcomes in adulthood, and then creating meaning. And we know that creating meaning out of adversity really fosters resilience. So, what kind of psychotherapy of these models, or if there's another model that you know of, because these aren't the only evidence-based treatments for complex trauma, would you refer Olivia to? Anyone have a thought? You could put it in the chat. EMDR, IFS, those are some other good models. CBT, trauma-focused CBT play therapy, somatic experiencing. So it's challenging without having a secure adult to go through the treatment. I would argue her new foster parent would need to go through the treatment with her. Even if it's just a new foster parent, it's forming a healthy attachment with the current person she's with. So I would say that you always need to involve a caregiver, and if that's the person she's with, then that person should be involved in therapy. Attachment focus, play therapy. Yeah, there's not a right or wrong answer. You know. And you know, the thing is, like, things like play therapy is involved in a lot of these. You know, play therapy is important in kids this little. You know, like when I work with kids with complex the trauma this little, things like, you know, the drawing and the doll houses and the puppets and all of them are so helpful. But I still argue to use them within an evidence-based treatment, because there's so much room to use things like sand tables and play therapy, like within the context of something like the attachment regulation and competency framework, and you're still getting those really potent ingredients of like an evidence-based framework or trauma-focused CBT. Like you can integrate those things right in there. So that would be my argument, that some of these things, things like, and some of the ones we mentioned, I think are really good treatments. I would just be careful about the age, 5 years old. Although a lot of them have been translated into child models at this point. And my argument would always to be to involve some kind of adult, you know, that's the thing, like when that's really hard sometimes when we can't find an adult to include in therapy. So I'm going to open it up for questions in the last few minutes. I'll also just say that when they're this little, if they're not responding to the psychotherapy with the parent or caregiver, especially like if it's going to be a long-term person, is just as powerful, you know. So like I wrote a paper and we're really advocating for insurance to pay for caregiver only psychotherapy because when the kid or adolescent is not ready, or like that parent or caregiver psychoeducation about how to work with kids with complex trauma, or they have their own traumatic experiences, all of those things we were talking about, and dealing with the parenting stress of raising a kid with complex trauma, or them coming into your home with kinship care or non-traditional caregiver, that can make all the difference. So really even working with the parents is huge. So in our trauma clinic, we were really, and they still do over in behavioral medicine and psychiatry, we often tag team, like someone takes the kid and then another therapist works with the parent, and then they have some family sessions, and you get some really powerful outcomes because you are supporting that caregiver and they're getting their own support, and then you're coming together. We've seen a lot better outcomes when the caregiver has their own psychoeducation and support with the parenting stress and often their own complex trauma issues, and then you're coming together.
Thank you, Dr. Bailey. It was a great presentation, and I just want to be mindful of the time since it is 12:59. I did put a link to an evaluation survey if everyone could please just take a moment to take that. And Dr. Bailey, one of the questions was asking if we could send out this PowerPoint. Is that okay with you?
Sure. Some of the slides are borrowed from the support group that psychoeducation group I do on the ARC framework, but they are open access, so I can send them out.
Perfect. I'll make sure to get that to